Hi everyone, I'm Daniel Lugassy. I'm an emergency medicine physician and toxicologist. I'm part of the Department of Emergency Medicine at NYU School of Medicine. I'm really excited and grateful that SEM has given me an opportunity to present this innovations presentation virtually. The project that I'm going to be talking about is Demystifying and Destigmatizing ED-Initiated Buprenorphine, a standardized experiential faculty development. I'm here at the New York Simulation Center for Health Sciences, which is a joint partnership between NYU Medical Center and the City University of New York. Even with a slight decrease in annual deaths in 2018, the U.S. is still in the midst of a terrible opioid epidemic, with about 130 deaths each day. Those who survive overdose have a 5% one-year mortality. D'Onofrio's landmark study demonstrated buprenorphine paired with referral in the ED decreased 30-day reported substance use and increased likelihood of being in treatment. BUP in the ED is feasible, highly effective, safe, and life-saving. But we are not doing enough. Despite the overwhelming evidence of BUP's benefit, it is rarely initiated in the ED. There are several barriers, and we aim to address two of the top barriers. One, many ED providers are just not familiar with BUP, indications, dosing. And second, stigmatizing language and behavior toward folks with substance use disorder is a huge barrier. The primary goal was to increase the likelihood that EM providers will administer and initiate BUP treatment for patients with opiate use disorder in the ED. Our two objectives were to enhance providers' ability to properly screen and treat with BUP and improve communication skills, specifically avoiding stigmatizing language. We created a group objective structured clinical examination, or GOSCE. We trained standardized patients to portray 3 commonly encountered patients with opiate use disorder. The first was a 33-year-old man who was brought in by EMS after an opioid overdose and was given naloxone in the field. He's now awake and wants to leave the ED. The second is a 35-year-old man who presents with requesting detox from Oxy and wants to be admitted. The third is a patient whose status post-IND of an abscess, secondary to IV drug use, who's requesting pain medication. Learners are sent Pre-GOSCE Materials, which include a comprehensive ED-initiated buprenorphine guide, and also a document on why it is so important to use non-stigmatizing language and examples of non-stigmatizing language for substance use disorder. The BUP GOSCE is about a 2.5-hour experience and starts with all the participants together for an introduction and pre-briefing. The participants then move to different rooms and stand outside the room and look at a door sheet. This gives them background information as well as physical exam and vital sign information. As you can see here, the participants review the door sheet, and then they enter the room. In this case that we'll be following is case 3. As the participant is involved with the patient, the faculty and the other participants are observing at the same time. We then, after about a 10-minute case, move to a debriefing. This is semi-scripted, and about 5 minutes before the end of the debrief, the standardized patient comes in to give feedback to the learner about their interaction. Here's a couple highlights from that case 3. We talk about how this patient is in severe withdrawal. Despite her low readiness to quit, there's still an opportunity to treat her with BUP. We talk about using non-stigmatizing language, and we examine our own bias and try to change the narrative around drug-seeking behavior. We then come together after 3 cases for a closing debrief to discuss moving forward and other barriers. So I'd like to share some of the pre and post data that we obtained. 39 of our ED staff completed the GOSCE, 31 were attendings, 6 were PAs. We had a total of over 350 years of EM experience with a mean of about 10. Interestingly, we saw 50% of our staff before the GOSCE had never administered BUP to any ED patient. and only 35% reported 1 to 2 patients. 22% had X-wavered before the GOSCE. When looking at comfort administering BUP, we noticed a statistically significant increase in the comfort administering buprenorphine pre- and post-questionnaire data. 1 being not comfortable at all, 10 being very comfortable, it went from 3.81 to 8.03. When looking at comfort discussing substance use disorder, we again saw an increase. It was not statistically significant, but this was likely due to the fact that participants already rated themselves quite comfortable discussing substance use disorder. In conclusion, we felt that the GOSCE was effective in increasing comfort with administering buprenorphine. It aided the approach to screening and administration, and it facilitated the use of non-stigmatizing language. So we want to share some comments that we received in the post-survey from our participants.
This improved my ability to explain BUP to patients, feel more confident about dosing and contraindications, and helped me understand the safety profile.
One scenario was very difficult, but largely reflects the difficulties I've had while working in the ED. I was able to watch a colleague interact with a difficult patient, and the debriefing was very helpful. I'm a huge fan of simulated learning because it's great practice. Just watching a video doesn't allow you to be put on the spot and react.
Thank you. This is absolutely practice-changing for me, and I'm looking forward to my chance to use BUP to make someone's life better.
In our 6-month post-survey, the respondents noted that 64% of them said that they were screening for BUP more often. They're more likely to use non-stigmatizing language, and they had an increase in empathy and compassion when caring for folks with substance use disorder. In our next steps, we want to train more providers. We are then in the process of getting IRB approval to examine the clinical impact. So we're going to follow pre- and post-practice patterns before and after the GOSCE. And then we are working on, in this world of social distancing, a virtual GOSCE format. I'd like to again thank my co-authors and additional teaching faculty, as well as the NYU Department of Emergency Medicine and NYSEM. We'd love to hear from you, so please reach me at this email.